Hi everybody. Our drug for the video is Methotrexate, and it's by Haley and Tyson. The class of the drug, it is a DMARD or disease-modifying anti-rheumatic drug. It is also an immunomodulator, immunosuppressant, anti-neoplastics, anti-metabolite. Some brand names for it could be Rheumatrex or Trexol, and then some other names are Methopetrin and also MTX. Here are some dosages that I found. It's going to vary from each individual. It comes in an injectable solution, powder for injection, a tablet, also an auto injector, 2 auto injectors, which are mostly used for the cancer treatment. And then here are just some general dosages that I found on a website for like neoplasms, osteosarcoma, and also rheumatoid arthritis, and then psoriasis, head and neck cancer, and cutaneous C-cell lymphoma. If you want, you can read through the dosages. That was just a general idea. It's going to vary from person to person. So some indications: it is disease-modifying drug with immunosuppressant and anti-inflammatory activity. It is commonly used for the treatment of RA and psoriatic arthritis. It is also classified as an anti-metabolite, cytotoxic agent, and is the most common first-line agent for RA. It is also used to treat severe psoriasis. It is also used in combination with rest, PT, and sometimes other medications to treat RA. It is used to treat certain types of cancer, including cancers that begin in tissues, such as in the uterus, breast cancer, lung cancer, cancers of the head and neck, lymphoma, and leukemia. It is also used to treat Crohn's disease, MS, and autoimmune diseases. Administration, so orally, it comes as a tablet to take by mouth. The schedule depends on the condition you have and how your body responds to the medication. You can administer by an IV push, IV infusion, or also intrathecally. And that's it. Or subcutaneous, which you can administer in the thigh or abdomen. Some precautions or contraindications. So do not use if you're pregnant. Women with childbearing, women in the childbearing age shouldn't use it due to the teratogenic activity. If you have alcoholism, alcoholic liver disease, or chronic liver disease, you should not use. If nursing, do not use due to serious adverse effects to the infant. Also, do not use if you have immunodeficiency syndrome, any pre-existing blood problems. Do not use if you have a known hypersensitivity or allergic reactions. Also, liver impairment again, active infections, immunodeficiency syndromes. And do not have immunizations or vaccinations without the consent of a doctor. And these are just some adverse reactions. You can read through them.
Sure. All right. And now we just want to get into a little bit of the pharmacokinetics here. So for the absorption, the bioavailability of methotrexate is going to be 60% at doses that are less than 30 milligrams. And then it's going to be less at doses that are greater than 80 milligrams. And that's just that absorption of that drug into the bloodstream. As for distribution, it's protein bound by about 50%. And that volume of distribution initially, it's a steady state there. As for the metabolism, it's metabolized by the liver and intracellularly metabolites polyglutamate forms. And as for our elimination, the half-life, psoriasis, RA, and low-dose cancer treatments are 3 to 10 hours. And for those higher dose treatments, it's going to take a little longer. It's going to be around that 8 to 15 hours to eliminate the drug from the system. Excretion is going to be in the urine 80 to 100% within 24 hours. And then also some small amounts of methotrexate are excreted in the feces. So how does this drug work? The mechanism of action for methotrexate is it inhibits dihydrofolic acid reductase. It also inhibits purine and thymidyllic acid synthesis, which interferes with DNA synthesis, repair, and cellular replication. The cell cycle specific is the S phase of the cycle. It also may inhibit rapid proliferation of epithelial cells in the skin. As for monitoring patients on this drug, to monitor patients closely for bone marrow, lung, kidney, and liver toxicities. Fecal blood tests are also advisable for a period of 2 weeks until 6 weeks after the last dose. If it is stable, then monthly until the dose and disease is stable for 1 year. Monitoring may reduce in frequency based on your own clinical judgment there. As for more tests, liver function tests should be done every 3 months. Urine testing for protein and blood can also be done, and urea and electrolytes can also be tested every 6 to 12 months, just to keep up on those. Some special considerations that you always want to remember while using this drug. Again, do not use during pregnancy, as those teratogenic factors can cause some problems there. The risks outweigh the benefits. And it's not recommended for women with that childbearing potential because of that activity. So why do we care about methotrexate as physical therapists? Well, methotrexate is used along with rest and physical therapy for treatment of severe RA is its most common use. Methotrexate helps to block inflammation and reduce pain, swelling, and stiffness in patients with RA to protect the joints so that PTs can work with the patient. Knowing the side effects of the drug can also be beneficial for us when working with them, and knowing when and how they take the drug to know when a good time is to work with them so you can schedule their therapies around those times. Knowing that higher doses to treat cancer will cause more severe reactions. A couple of things to remember is to notify their physician immediately if patient experiences signs of pulmonary fibrosis or pneumonitis, such as dry cough, shortness of breath, cyanosis, and fever. And also to monitor any sign of unusual weakness and fatigue due to possible anemia. A couple more things, just report signs of arachnoiditis after intrathecal administration, which can include numbness, tingling, weakness in the legs. Assessing any musculoskeletal pain that might indicate osteonecrosis, stress fracture, or soft tissue necrosis. If treating a patient with RA, periodically assess the patient's impairments, functional ability, and disability to help document if that drug is actually working. If treating psoriasis or cutaneous fungal infections, assess healing of skin lesions to help document if the drug is working as well. And then just assess dizziness that affects normal everyday activities such as gait, balance, and functional activities. All right, so we looked at a couple of different studies. The first one looked at a case where an individual wasn't diagnosed originally, but he had Stevens-Johnson syndrome after he started taking the methotrexate. So he was taking methotrexate for rheumatoid arthritis, and after a couple weeks, he began forming oral ulcerations and itchy erythematous rashes on the body. So the medication was then stopped, and the patient was prescribed different medication. And the sores did start healing then, and he did get rid of that itchiness. So just something to remember, just from looking at this study, is be cautious with patients because there is an increased risk of skin reactions that they may think could come from something else. But if you know that it is, they did just have a change in medication, that methotrexate could be causing it. And then the second study we looked at examined the effects of methotrexate on tumor necrosis factor. The study involved 39 women with RA taking methotrexate and a different DMARD, which is infliximab, or just the infliximab itself. Tumor necrosis factor bioavailability activity was measured throughout the study, and it was found that the individuals taking the methotrexate with the infliximab, the bioactivity of TNF was reduced more than the other DMARD, which was just the infliximab by itself. So here are just our sources that we used for the presentation. If you have any questions, you can comment below in the box. And thank you very much.